Ministerial Advisory Council. We also have a group of scientists in our province drawn from institutions in our province and our public health institutions, as well as our universities who have been working with us. Today they are going to share some information. Part of that is the modeling issues, modeling the pandemic in Gauteng province, including the work that they have been doing so far, including where we are now. This is the beginning of July. We've just gone through June. June has been a very tough month for Gauteng province because we have seen in June exponential increase in the number of cases. That includes a sharp increase in active cases. There's also been a significant increase in the number of fatalities in the process. So June has been a very difficult month. We are now at the beginning of July, and would like to say July will even be more difficult than June. We want our people to understand this, how the various work being done by the scientists is helping to reinforce the fight against COVID-19, to help us focus on the areas that matter most, but to also ensure that our response is informed by data, is informed by evidence, is informed by science. So that's the reason why today we are going to start with the presentations from firstly, it will be Professor Bruce Melado. Professor Bruce Melado is a member of the Advisory Council. He's from Wits University's Temba Labs. He is going to share with you at home and the media here the work that his team has been doing around modeling, including where we are now, including where we are going. We will also get a presentation from Dr. Bukosi Maribate, who's a data scientist. He is also going to bring in the conversations and the work there, the work they have been doing and how that work has been informing the Provincial Command Council, but going forward, because there's going to be the need for a change of gear, and that's this. When we come back later to conclude, the MEC for Health and myself are going to communicate to you on the need for the change of gear, given what is taking place in our province, given the overwhelming then this is beginning to place on our public health workers. Some of those areas where we're going to need a change of gear will also be guided by science, but also be guided by what is happening exactly in our communities in Gauteng province. Dr. Maribate will be followed by Dr. Mary Kawonga. Dr. Mary Kawonga is from our Department of Health, and she chairs the advisory committee. She works very closely with the MEC for Health in that regard, and she is going to be sharing. She also comes from the Wits School of Public Health. She is going to be sharing with us on the basis of modeling, on the basis of the data that has been done to map the pandemic in Gauteng province, what has been the planning. So she will talk about planning for the peak and planning for the period that we have just entered now, what the gap has been between available resources and the resources that will be required later, and what has gone into that work to deal with the gap. And we will, after Dr. Kawonga, we will get Professor Steve Muyeng, who's a trauma surgeon, to share with us from the perspective of the clinicians who are in the cold phase, basically, right in the hospitals, Professor Muyeng is a trauma surgeon at Chris Hani, at Charlotte Maxeke, and he deals on a continuous basis with looking at what is happening in the wards, particularly the trauma wards. Once they have concluded with their presentations, basically sharing the information that has been informing the work of the Provincial Command Council in Gauteng, I will get MEC Masuku to indicate where we would need a change of gear, what the Command Council has been discussing around the need for us to strengthen our response given the new conditions, given the prevailing conditions that we have entered now. Now we are in July, we are getting into August, and essentially the critical issues as to when the peak will be based on modeling, that time is now to be able to face up to the storm. The storm has arrived in Gauteng, the COVID-19 storm, but it is within our power, it is within our capacity as the people of our province. Every sector without exception can do something to ensure we weather the storm. The storm is coming, there's no doubt about it, it is here, but the critical issues is that we have to look at a number of interventions to help us weather the storm. Again, even those interventions will be informed by the advisory committee in terms of their full impact. We don't want to do something for dramatic purposes, but without achieving the results. But it is quite clear that we're going to have to do some of the things, given where we are now, that are essentially extraordinary, and some of them may mean asking the National Command Council to introduce some of the restrictions we have had in the earlier phases. I will come back to that at the end after Dr. Masuku to say this is the process that we are undertaking over the next 3 to 4 days. So I would like to welcome onto the stage Professor Bruce Melado to come and share with us information relating to the modeling of the pandemic here in Gauteng province and what that has helped us to do in responding to the situation that we have come out of in the previous months, but also in preparing for the situation where we are now. Professor Melado, please come over.
All right, can you hear me? So first of all, I'd like to thank Honorable Premier for the opportunity. As the Premier already indicated, I'll be talking about how modeling works and how we are helping policymakers take data-driven, evidence-based decisions. I'll be talking on behalf of the team of Wits University and Itemba Labs of the National Research Foundation, supported by the Department of Science and Innovation, and with very close collaboration with the Gauteng Province Department of Health. We also have partners like the GCRO, IBM, and the IEEE that help us, that support us in different ways. Can I use this? All right, so first let's talk about how do we build a model. It's very clear. that modeling a pandemic is a complex problem, and we have to attack it in a very particular way. The result of modeling, the result of the pandemic and the evolution of the pandemic is the result of the interaction of many different kinds of peoples in many different kinds of ways in a very heterogeneous ecosystem. So as a result of that, a model has to be developed by a team that is interdisciplinary, that starts with inputs, then goes through some mathematics, rules, and parameters, and gives outputs to policymakers to enact certain regulations, advisories, and so on and so forth. So the work has to be done by a large team of people, and hence the need for collaboration and establishment of partnerships, in particular with the Gauteng province of health, that provides invaluable input to the modeling, so that the modeling is not just an abstract construction or a mathematical construction, but is really reflective of the reality on the ground, meaning that we are describing the real number of hospitalizations, different kinds of hospitalizations, etc., etc., etc. So those go into inputs. Later you have a bunch of mathematics and rules and inputs from epidemiologists, clinicians, public health specialists, physicists, engineers, statisticians, and data scientists. And that is what makes up a model. And then there's a bunch of inputs and a bunch of simplifications that are made so that we can visualize a very complex picture in a way that can be understood in a broad context. We don't want to be too technical, we don't want to be too mathematical, and that is what goes into the inputs. Into the outputs, excuse me. And those outputs are used by policymakers. So you have to build a model, you have to build a mathematical model, and the reality is that this pandemic is different from any previous pandemic. It's very specific because A, is very contagious, and B, you have a large number of subjects that are asymptomatic, that don't display symptoms, but yet propagate the virus. So we have basically to deal with two distinct systems that talk to each other somehow. One is what we call the latent dynamic, meaning you have a lot of people that may be carriers of the virus that don't feel they have a virus, but they pass it on to others. And then you have other community within that community that is infected, feels symptoms, and interacts with the healthcare system. So we have to be able to model both. This mathematics was validated with data globally, and it's applied in the South African context with South African parameters. Okay, so the model is South African in that sense. There are important parameters, of course. There's many parameters that go into the model, both intrinsic to the mathematic and also intrinsic to the data, but it's the two main parameters we have to control. One is the stringency index of the measures that policymakers enact in order to control the pandemic. We have adapted an index developed by Oxford University in the South African context, and then comes the efficiency of those measures in controlling the pandemic, which in essence means or gives a measure of adherence of the population to those measures. And we are able to dynamically, as the data comes in, to recalibrate the model as new data comes in to be able to make predictions. That's the methodology that we pursue. The stringency index of South Africa is on the basis of this 5-level alert system that has been enacted by government. You can see in the graph a distribution of the stringency as a function of time. It's a time series, and you can see how gradually the system is being relaxed. And as it's been relaxed, the model responds and provides certain predictions. The index is composed of a number of indicators that range from how schools are closed and how they are being reopened all the way to international travel bans. This is a graph with all the data, but illustrates how we work. How do we interact with the data that we receive from the Department of Health and other sources? How do we readjust the model to make predictions? This is a graph that we made back at by the end of May, where you can see that back then, we were at level 4. This is how we readjusted the graph. Let's focus on the red curve only, and you can see how well the data follows the readjusted model, and then the model is able to make a prediction of the evolution of the pandemic at large with average quantities. Like that would be the provincial, so to say, model. As you know very well, and as already the Premier has indicated, we have a surge in the number of cases that is driven by what we call hotspot dynamics or hotspots that you could see already on the graph indicating a certain growth. And please look at the red dots. And that is what we are now have incorporated into the model. The evolution, the creation and evolution of hotspots on top of the provincial modeling. This is a graph here that it's of course made of many inputs. There's a lot of information that comes from the Gauteng Province Department of Health, and it compiles basically data that flows from different points and different stakeholders in order to provide us with a realistic picture of inputs. And you can see here a graph. Do I have it? No, I can't. The upper graph is giving you the total hospitalized cases as predicted in May using May data. As you can see, that the number of hospitalizations as of June 27th is slightly higher. We've had a surge in the past 3 days that is the result, the result of those hotspots I was talking about. But this is basically gives you a measure of how these models are working and how they're helping policymakers take decisions. We work, as I said, in partnership with various stakeholders. That includes IBM. There is a tool that has been developed by them in collaboration with us and other stakeholders. You can see there a snapshot and a slightly older snapshot of the hotspots in the province. You basically have a heat map that helps policymakers concentrate their attention in a geospatial picture. You can see there that it's providing a temperature mapping of what's going on at that particular time. That graph is about 2 weeks old. In reality, this tool sits in the room of the command center, and experts and policymakers look at it every day. This tool is continuously updating the visualization of the hotspots as the data comes in. A very important element that I just mentioned earlier is to incorporate the evolution, the identification, location, and evolution of those hotspots in the province into the overarching model. And for that, we have to use what we call, it's a bit technical, clustering algorithms or clusterization algorithms using artificial intelligence. Artificial intelligence allows us to create groups of people that appear to be somehow getting sick together, creating groups and clusters that policymakers and the corresponding stakeholders have to go and intervene. This uses, of course, artificial intelligence. Why? Because we have to learn from the data itself as the data comes in, because the data is very complex. And artificial intelligence is a very powerful tool that scientists use in order to solve a complex problem that comes from the data. Now, these hotspots are now embedded, are a part of the modeling of the province, and they have a life of their own. And what we will be seeing, as the Premier already indicated, we're going to see continuous growth. We're going to see hotspots going up and down, the new hotspots appearing. And now that we have a complex apparatus to follow up and to predict and help policymakers, we'll have a more accurate picture to deal with them. Thank you very much.
So Dr. Marivat is going to take it from there and just go back and drill into the data. I didn't say that he is from the University of Pretoria. I know it's very, very important when you work with academics. I said Bruce is from Wits University, so I can't not say he is from the University of Pretoria. He will feel very offended. Dr. Marivat, over to you.
Okay, good afternoon. Thank you also to the Premier and the leadership team of the Gauteng province, also for inviting us to present some of the work that we've been doing. We've been serving on the advisory committee. So I'm at the University of Pretoria, but represent not just that, but also collaborators and contributors from all over the country and also partly all over the world who've been working on looking at the way that we can inform data-driven decision-making in the COVID-19 response here in South Africa and then also in Gauteng specifically. So first starting off in a more higher level view, we initially started with our work. We're trying to make sure that we can make available as much data as possible on COVID-19 in South Africa in an open manner that allows other scientists, researchers, and the public to be able to understand the spread and also be able to do science, to do modeling, to do kind of analysis. So this work went through looking at the public releases of data, finding any other additional information that comes from official sources, putting it in one place, cleaning it, providing tools for data mining, and then making it available on a data repository that we've now been running since the beginning of this pandemic here in South Africa. The repository itself is open by default, meaning it's free to use, free to get the information. And this was done again to make sure that people have access to these and then it's not behind any restrictions on that part. We've been tracking data that has to do all the way initially when we had data about individual cases. Now it's provincial information, information that comes in from different statistical bodies here in South Africa, and now also down to each of the provinces. So we actually make that information available for others to use. What does this allow? Sure, we can have use cases where we can show an example of a dashboard that we built just to show what's possible with that data. It's not the end-all and be-all of what we're doing with that information that is accessible to the public, where they can go down to actually looking at provincial level data, looking at some analysis that's quickly glanceable. But then it also gives other people ideas on what they could do. We do have, as Prof. Malado before me spoke about, with some of the modeling that needs to happen, you need to have access to this the data like this, and this data does feed into people like IBM who then do use it on their dashboards that are available here, and then also other teams across the country who are also working on modeling. But the reason that we want to work in this way also is that it encourages open innovation, and some of the things that we've seen is, for example, translations of these dashboards. Here's one in Xitsonga that's available to make it, again, making the information that we have about the spread being accessible to more people in the country, not just defaulting to one language on there. And about 2 weeks ago, there's another one that now became available in Chivenda that allows more people from that community to actually access this information and be able to make their own decisions and also understand why we're calling for a response that is not simply the leadership, politically, but then also down to the communities of why this, this call is very important. So if we come down to Gauteng, our interactions with the advisory and also with the leadership of Gauteng has been on now, how do we use data science down to getting to decision making on there. So we have the modeling, we have analysis that's being done, but you need to think about then how this then converts into decision making, right? So we have to then ask ourselves at multiple stages, what actions need to be taken? We've been seeing this on, we've had to have lockdowns and lockdowns being eased. Now you have to think about the health system and how it's actually responding, and what are the feedback timelines. As we're moving closer to our peak, we know that those timelines are getting shorter and shorter and shorter. While before, maybe we could do with waiting a few days for a decision to go on, now we're down to a few, a day or two, or maybe even hours on decision making. And we need to then move to finding ways to get to real-time situational awareness. So the work that we're doing through myself and the collaborators and contributors working on is advising on ways that the health information systems can work in a much more real-time manner and then be able to provide information not just to the Premier or the MEC, but all the way down to clinicians and management inside places like hospitals on there. So if we think about a use case, one of the things that we've been investigating is how do we get people to better understand the capacity and the capability of the health system, and then also provide a framework that then can be used to move it into real time, where we can know if there's specific facilities that are struggling and they might need help for other facilities, or you can actually balance between kind of the two. This again becomes more important as, again, we're having more and more cases here in Gauteng, and we're still building onto these to this data. We're bringing information for both that covers the private sector, the public sector, and we're trying to update it as much as we can, and working with Gauteng Health in trying to see how these things then end up in their systems. Almost at the end, on just thinking about the process, and this is again to bring the public into confidence, is that when we're doing decision making with data, we need to kind of follow some recipe to make us more comfortable with what's actually kind of going on. We want to get to a point where the analysis and the modeling is getting to the ground. It is not simply something that we talk about, but it's actually not changing things on the ground. This means that we do ask ourselves with the Premier's team and with the advisory team, what decision does the data, the analysis and the modeling actually inform, and how then can we now validate and make sure that there's compliance in some spaces on there, right? And then how, the next questions that are coming up is how do we move then to working with all health facilities as much as we can, so that they also can inform us in giving us feedback on things that then could get back to them, right? Sorry. And then there's the question of the frequency of updates that are required in this part of this decision making that is going to be there. Again, that's connected to the decision making part. You can't wait a week or having a delay. We know at the beginning, when we're looking at the numbers that are coming through, we also need to understand that a number is not simply something that just comes out of thin air. We understand that there's multiple systems in testing, in doing tracking and tracing, and understanding communities, and also understanding how society is actually reacting to the COVID pandemic. So through that, we then need to also take this into account in the way that we now say, okay, how fast can we actually get data in, and then also kind of have a turnaround time for us to actually make a decision on there. Let me see. One of the things then to get to this point is that we need these combined views where we're getting data from Gauteng Department of Health, National Department of Health, there's data that's coming in from NICD, the Medical Research Council, private healthcare, and also open data, just as the project I showed you at the beginning, where we're working on that. And this means that it all has to come together into one space. And this then brings in things like interoperability, ways to be able to validate and confirm. But the other thing that I think we all have to be cognizant of is that health is not the only consideration. It's just that at the moment, that's the thing we're trying to chase, just because of the realities of that we're seeing with the impact of COVID. But the impact of COVID is not just on health, right? So there is other pieces of other lenses that we need to look at on either societal or even economic that need to come in, because we know these things interact with each other. There are reasons why we've been changing lockdown levels. It's not simply because of the health. It's because of also other factors that are socioeconomic that we're looking at on there. So thank you for the time. And as I said, this is a project that is being run by multiple contributors and collaborators who are all working, trying to make sure that information is available, data is available, and at the same time it also comes through into the advisory committee through myself, and then also interacting with the rest of the advisory who are working on data and modeling.
Thank you very much, Dr. Marivate. Thank you very much. And I think you may take a seat, Dr. Marivate. So essentially, the first two presentations, every time we do the weekly media update, you need to know that at the back of the information we share with you is the work that's being done by our advisory council. The information we bring here, the data tracking, the shifting hotspots, as we've always been saying, the shifting geography of the hotspots, where the biggest problem is, where is the outbreak, why do we have this taking place in a particular area. There's this work at the back of that That analysis is informed by the work that our modeling team does and our data team does. But the work they do also informs other decisions, planning for provisioning, and that's what I would like to ask Dr. Mary Kawonga to come and talk about. Based on the work that they have done, how have we been planning for provisioning human resources, additional beds for the periods that both what we have gone through now, the month of June, but the July, August period, that's the critical period we are going into. Dr. Kawonga, please take us through your presentation.
Good afternoon. Thank you very much, Premier, MEC, and colleagues. You've just heard from the group that's been doing the modeling and the data scientists, and these are the number crunchers. And so, as Premier said, my role now is really to talk about what do we do once we get those numbers that they're then developing, because there's a process that then follows thereafter. So I'm just going to sort of touch on some broad strokes. And so, I mean, one of the things we've been doing in the Department of Health, so I'm standing here representing a group of people in the Department of Health, including colleagues, health economists, statisticians, and others, who've been sort of thinking quite carefully about what do we do once we get the modeling numbers. We need to have an approach. And so I'll share with you just the approach that we followed, and this is what we're then able to provide to the decision makers such that they can make sense of the numbers. So we followed this approach that's on the slide here. So there are a number of questions you need to think about and ask yourself when you're planning for resources. So as previous speakers have spoken about and as Premier have spoken about, we all knew that COVID-19 cases were going to go up. It was inevitable. That was going to happen. I think the lockdown allowed us to sort of delay the peak, but we knew that it was going to come. So we did have to start planning for the peak. So there's what I'm going to talk about is really about how the process we followed to plan, but I'm going to talk particularly about hospital beds. And I'm sure you'll probably understand why we're looking at hospital beds. Because I think once an epidemic has gone into community transmission, and transmission is widespread, and containment has not quite stopped the spread, it's inevitable that we're going to get people coming to hospital. They'll be admitted, they'll require care, and as we've seen from other countries, they will require critical care, they will require ventilation, so they require high-end care. And that's the kind of care that's not available readily in any health system. Even very well-resourced health systems in Europe have struggled to be able to provide within their existing capacity. So what it means is we do have to start planning for additional capacity, and so this is the process we followed. So in terms of hospital beds, the first question in planning is you ask yourself, how many beds am I actually going to need? And this is where Prof. Malado and his team come in, because they provide models. As he mentioned, these are models that they developed to predict a particular outcome. So they were able to predict the number of beds that the number of people we expect to have COVID-19 over the next few months. And then based on that, they also put some parameters into the model and were able to provide numbers for us on how many people do we think will be admitted and requiring different types of hospitalization. So there will be people who need ventilators, like I mentioned, then those are the very, very sick. Then there are people who have moderate illness, and then there are people who may just require oxygen therapy in hospital. And so we needed to plan for all those types of beds in the public sector. And so that's how the modeling assisted us. So that's the first thing that you need to think about. And then after you've done that, you need to look at where am I now? So you've already established where you want to get to in terms of the number of beds you're going to need. But the next question is, where am I now? How many beds do I have available now at this moment? And so that was now obviously the work of the department to do an audit, to go to every facility, and to determine how many beds can we actually put aside for COVID-19. So obviously we can't use all our hospital beds for COVID-19 because other health services have to continue. And so there had to be some process to define how many beds are we going to be able to put aside to care for people when they come to our hospitals for COVID-19. So that was the next step. So once you've figured out where am I now and where do I want to get to, you then have to ask the question, what's the gap between where I am now and where I want to get to? So how many beds do I have now and how many do I need in the future? The difference between those two is what we refer to as the resource gap. So that's the bed availability gap. And so we defined what that gap is. And then once that gap was defined, the next process, which is what the health officials in the Department of Health, with support from the Premier's office and others, now have to start thinking about how do we bridge that gap. So in other words, how do we create additional hospital beds to cater for the expected surge in numbers? And that's quite an intricate process, and I'm sure though some of that detail might be shared at a different point in time, but I just want to highlight the key things that people ask. So the first thing is how many available beds do we need to create? But then once you've created those beds, the beds don't run themselves. You have to have health workers to run the beds. The beds might require a ventilator. The beds might require different types of equipment to make sure that we can provide oxygen and other services to people. So the process that I've just described is sort of the rational step-by-step process that was followed. And what it's trying to show is the modeling actually has links to what happens on the ground ultimately in terms of our ability to provide beds to people that are sufficient and sufficiently equipped and so on. So that's really the process that I followed. And I'm showing this picture, and unfortunately the acknowledgement didn't show up there at the bottom. But this picture really just encapsulates what I've just talked about. And this is the advice and the recommendation that came out of colleagues and people, not colleagues since I don't work with them, but people who worked in the epidemic in Wuhan, where COVID-19 originated. They realized the importance of doing predictive modeling to help you predict how many beds you're going to require. And they also realized the fact that often it's the critical care resources. So these are the very sick who require high-end care, very high-end ways of delivering oxygen and also ventilation. And they recommended this process that's in this diagram, which is you start, you know you have a lack, so you then have to develop models that help you predict how many people you expect to be in hospital, and then you create the resources that are required. So it's a well-known process, and it was really very useful that there was already best practice from somewhere else to guide us. So I'm not sort of going to the details of the numbers, but I think just to give a summary of what we found in terms of the gap analysis. So what the gap analysis showed us was that in the short term, and you know, short term was till about end of June rather, the available critical care beds and general ward beds in Gauteng were sufficient to meet for the predicted number of cases who were going to come to hospitalization. But after 30th of June, the prediction was there was not going to be enough beds. There were not going to be enough hospital beds to cater for the patients in hospital who needed critical care and the patients who did not need critical care. So these were not going to be enough to meet the demand, because by the end of July, the expectation was there was going to be a gap, quite a significant gap. And then the peak was expected to occur early in September, and the gap was even bigger by the time we got to the peak. So what this was telling us was, don't wait. We can't wait till end of June to start saying, oh, let's now start planning. So the idea was you need to start planning now and start creating capacity as you go forward. And so what was needed was the Gauteng Department of Health needed to create additional bed capacity, including 410 critical care beds and over 1,000 high care beds by the end of July. And obviously there were more beds required by the time we got to the peak. And so then after the gap analysis was done, obviously then work started to try and start creating this capacity. So the department has adopted a phased approach. And the phased approach was very much in line with the guidance that has also come from the National Department of Health and the World Health Organization about how to create additional capacity for your health system. And so what's often is advised is use whatever you have in your existing hospitals as much as possible. So use the existing capacity as much as possible first before you then start creating additional beds within the existing hospital system. But then if that's still not sufficient, what they recommend is field hospitals. So these are hospitals and other institutions or facilities that are created outside the existing health delivery platforms. And those obviously will be there particularly to cater for patients who have COVID-19 and require care. And it's different types of care that they would require. And so that's really the phased approach that's been adopted. And so the details of how far they are and et cetera in terms of infrastructure, the MEC and the Premier could deal with that. And I think Dr. Moeng will come and give a clinician's perspective on how things are happening on the ground. Thank you very much.
Thank you very much, Dr. Mary, for that presentation. So at this point, I would like, so for now, Dr. Moeng, I would like you to wait a little bit before you give us the on-the-ground situation feedback. I would like the MEC to come back and deal with some of the work we have done. That's the usual. We often do a presentation to you here that says how many beds, additional beds we have been rolling out. You will get that, and just the sense of getting into the period where we are now. What is the pressure? And that is the critical thing about today's briefing. When we get to the conclusion, we're going to be basically calling on the people of our province, various sectors, to say, if we want to weather this storm together, because we've got to weather the storm together, we're going to need particular interventions in particular ways. But at this point, I would like, so MEC Masuku is going to use the presentation that we normally do for our weekly update. He's going to choose in there what are the critical issues that fill in from where the presentations by our advisory committee, the gap was, how many beds just in the month of June and for this month of July, and what are we planning with regard to the beds that are going to come from field hospitals. Dr. Masuku, over to you.
Thank you and good afternoon, everyone, and thanks for the opportunity, Premier. I'm going to cover briefly the issues relating to our bed capacity and the work that we have been doing throughout the last 3 months that we have been dealing with the COVID pandemic. We have indicated, I think, from the modeling that the gap was anticipated to be visible and glaring when we started July, and also when we go towards the peak, which is expected to be around August, September area. So we had given you an indication that we have got like the phased-in approach, as Dr. Mary has said, that we would use and repurpose some of the wards and some of the spaces within our own facilities to create more space and beds in our facilities. And the second part was that we wanted to create permanent beds that will be added in different parts of the province. We did mention before that we were talking about Kopanong Hospital, 300 beds there. We are talking about 500 beds in Kresane Baragwanath, and another 300 beds in George Mokari, and another 300 beds in Jubilee. These are the beds that we are using alternative building technology because of the rapidness that we need them to be put up and to be set up, but also to have them in a more durable way to use them beyond the pandemic. So this is the first part of it, which is a long-term or the long-term viewish type of our response on the bed spaces. In the meantime, the important aspect to meet the gap that is actually left will be the field hospitals. You know that we had started the project and the program at NASREC. So the beds that we are going to put up on field hospitals are close to 2,500 in different parts of the province. The NASREC one is ongoing, it will be activated. There would be one that will be activated in Tshwane. There will also be one activated in Davidton, in Sinabe, in the East Rand, Ekurhuleni, and there will be one that will be activated around Midrand and Diepsloot area. So this is how we are going to make up for the actual beds that will be in need. But currently, since we had a discussion with everyone, is that we almost have activated 600 beds within our own facilities. This morning alone, we are launching the first phase of our 29-bedded ICU in Charlotte Maxeke. We are still going to open another phase in the coming 2 weeks. We have opened the beds in 40 beds in Kopanong, which have almost already started working. We've already started, some of the beds at Baragwanath Hospital, and the other phase that we are going to take you through to George Mokari, where we'll open another set of beds that will be there. So what we are trying to communicate now is that we have a systemic way of how we're going to address the issue of the beds and how we're going to address the issue of the services. The field hospitals will come in handy to make sure that the transition towards the peak, when we then combine all the capacity that we have in our hospitals, the capacity of the repurposed beds, the capacity of the field hospitals, and the capacity of the APT additional beds that we have put in, which I think would be there and in place at the time of the peak. Our aim is to make sure that all patients who require medical intervention should be able to get space, should be able to get intervention, and so on. We have also noted, which is something that we are going to address today, noted that the PUIs, the patients under investigations, are becoming a big challenge. Because of the winter season, we are seeing a lot of patients coming in with respiratory symptoms or with respiratory illnesses such as your pneumonias and others, which by and large we need to exclude actually COVID in them. So it's important that we then investigate them and confirm so that we can then triage them into a particular side of the hospital where they will be taken care of. But those PUI tents or the PUI triaging tents should be having capacity to be able to give oxygen, capacity to be able to give administration of IV fluids from actually management and all other important management that is required. So by and large, I think we will summarize our need on the field hospitals, our need on the APT within the space. But maybe as I conclude, when we come back, we'll have to then say to you that, yes, the system is feeling the pressure. Yes, the system is feeling the stress. And it's not only the system itself in terms of beds, it's also about our staff workers, our healthcare workers, who have day in, day out since the beginning of June, have been beginning to see the numbers increasing. The numbers, like last week when we communicated to you, have been surging up quite sharply, and that have been visible also in terms of the number of admissions that we've had in our facilities, which is something that we'll have to actually reflect on. So what would want to say as Gauteng and also put across to the public is that government also should play a role in calling on the public to play a role in making sure that the system does cope in terms of upholding and respecting the regulations, in terms of staying at home, in terms of making sure that they avoid overcrowded spaces, and also avoiding organizing unnecessary activities which will require people to gather in big numbers, such as some of the marches that we're starting to see and other activities that we have started to see at the level of weddings, after tears, and all the other social actually parties. So what I'm trying to actually come at is just to, in the period that I'm referring to, which I think the Premier will have to cover, is just to say that during the different levels of the lockdown, this is what the picture we've seen. You know, the skyline and the high rising that we are seeing. At some point, we made a very big issue about the number 260 when we saw it just towards the end of May, and we were quite alarmed about the number. We activated our programs in terms of tracing, isolating, and tracking, and that's how you see the response came actually too. But when we started to move to a different level of lockdown, then the number started to go very high and very sharply. And this is what I think is important for us to say, that we must deal with this in a different way and in a different aspect of it. And I would want to allow the Premier to somehow go through some of the things, but that's where we are. We are, of course, we will not say that we are not worried. We are pretty much worried. We are anxious about the pressure. We want us to change the gear as society. We also have to play a role as government to make sure that some of the regulations that we spoke about should actually come back, to give a breather to the system, to give the breather to the healthcare workers, so that we can be able to save lives. I think the whole ability is for us to be able to save lives, and I think it's an important aspect of the work that we have done. Thank you, Premier.
Thank you very much, MEC. So if I was just to summarize, so from the gap analysis, the work done by the modeling team, the data team, and the resource planning team, so the gap analysis especially from a bed's point of view, for June, 600 beds, the modeling teams said 600 beds will be adequate. We wouldn't run into problems in June. And those were done. That's the work, that's the phases that the MEC was talking about. Those beds were done in our existing facilities. Most of them are being handed over. In fact, the MEC is moving from hospital to hospital, region to region, district to district, getting those wards operational. So those beds for June, the work was done on that. For July, and I want to be precise, so I said 600. For July, the modeling said by the end of July we would need 2,077 beds by the end of July. When we get to the end of July, we will need that, and the reconciliation in the presentation by Dr. Mary there would show that currently we have existing construction work will give us over 2,077 beds by the end of July, by the end of this month. So there's work, in addition to the one that has already been done, those wards that are being opened, that are getting operational, that Dr. Masuku is going area by area. By the end of July, we will have this additional 2,000 beds. A lot of them, 1,500 of those are on alternative building technologies. That's the 500 that the MEC is talking about, and the 300 in Kopanong, and the 500 at Krisani Baragwanath, another 300 at George Mukari, and the 300 also at Jubilee. So those ones, the work is happening to ensure that they are ready. So in addition to those, you would have seen in the presentation by Dr. Kaunga that the modeling said you will still need more beds. And that's where the field hospitals come in. So I'm explaining the difference between those different sets of beds, both the 600 in our existing facilities and the additional 1,500 on alternative building technologies in our existing facilities, with the additional 2,500 that is the work being done on the field hospital. That work is being done for NASREC, and we're doing this work essentially with NASREC is the province itself. You remember that at NASREC we have essentially a quarantine site there, but we are putting additional actual beds there with oxygen points. And this I want to explain because it is very important. The clinicians' feedback to us is that for critical care, that's going to be important. You need ICU beds, but you also need as many beds where oxygen is available. So that would be NASREC, the area in Tshwane, the area in Ekurhuleni, on the field hospitals. We are working on the field hospitals basically with national government. The field hospitals are being done with the national government. This takes me to essentially the conclusion of today. We are not taking you through all the numbers. Again, we just want to take you through what our critical message today is to the people of our province. And this I will do in few minutes just to conclude. So firstly, we would okay, yes. Doc, let's get the feedback. Doctor, I forgot you. You are the trauma surgeon, so you must be traumatized yourself that you have been forgotten. We want Dr. Moyeng to give us a direct feedback on behalf of the clinicians on what is happening, including since the opening of alcohol sales, basically, but what's happening essentially in our hospitals, including where we have had beds that are available. What is happening now? Dr. Moyeng, please come over. In fact, it will give us a few minutes to just make sure the presentation we have there is the right one. Professor Moyeng.
Thank you very much, Premier, and thank you very much to the MEC. I'm just going to be brief. What I'm going to say, and I've been requested just to talk about what we are experiencing at the cold phase. The one concept that I want us to get very, very clearly is that unfortunately the COVID load is here. And the reason why I'm mentioning that is that some of us have still not changed our behaviors. Some of us are still not following the general guidelines. Some of us are letting our guard down, and unfortunately the brunt of what we are discussing is being experienced by the healthcare workers when we come into the institution. Just to give you a general idea of what we are facing, I can assure you that in one of our institutions, and I'll give you an example of the Charlotte Maxeke, is that we had found ourselves for a long time up to the mid of March, up to the half of April, being able to cope with only one ward, and that one ward could deal with PUIs, and it could also deal with the COVID-positive patients. In the past 10 to 14 days, what we have seen coming in is that we have grown from that one ward to more than 7 dedicated wards that are dedicated to PUIs as well as COVID-positive patients. We have identified, and obviously you must understand there's a need for us to be able to adjust and make the necessary decisions every time. So we decided in a hospital of that magnitude, and this you see as well in other hospitals, that it is important to form a joint operational committee. Why do we run that joint center? It's because every day you need to figure out how to distribute your healthcare workers. Every day you need to look at how many new numbers have come in and be able to adjust and make your way in an appropriate manner. Every day you need to be able to sit down and look at the loads and new patients that have come in and figure out the best way of being able to accommodate them on the field. And that's why I started by saying, if you don't believe it, I promise you what we are experiencing as healthcare workers is that our load and our amount of COVID-related problems and patients are going up. The other thing that we've noticed is that we've also seen an increased number of those so-called screen-negative patients that are coming in. And I want you to understand that it is not just about the screen features of your coughing, your temperature, etc., but we are also seeing patients coming in that do not fit that criteria. And when they are in hospital and you're operating on them, by the time you realize as well that they are COVID-related results. And that's one of the reasons why, with this kind of a joke, we found ourselves constantly having to adapt with the numbers that we are seeing in reality and be able to change our strategies. And I can assure you, in that institution, all of our admitted cases at the moment have to be swabbed, irrespective of what their screen features and their screen outcomes are like. And it is not surprising. You look at our ops and gynae, you look at our general surgery, you look at trauma, which is my field of interest, and you are picking up as well in children that not everybody presents with the classical signs and symptoms. What is the message from that? It certainly speaks to us as healthcare workers that we need to change the way that we approach, and we need to be careful on how we deal with every patient in front of us. But it also asks me and you, as communities and core members of this Gauteng, that we must not let down our guard, even when we are sitting together, even when we are socializing together. We must maintain the very same message so that there are less number of people that are admitted to the hospital. So to deal with this load that has gone significantly up in the past few days, and again related to the COVID numbers, we've had to figure out the way of putting minds together in one of those institutions and make the necessary adjustments every day. The next issue that I wanted to highlight as well from what we're experiencing as healthcare workers is that there is no way that whatever is done should compromise the healthcare worker. And that's why we've constantly said proper, appropriate PPEs. That's why we've had engagement with the MEC to make sure that at least we do our level best to offer them as much protection and as much training as possible. But there is no doubt that just like the numbers of COVID-19 are increasing in Gauteng, we are going to see more and more of our healthcare workers also affected. Not all of our healthcare worker exposure is always directly related to work. It might also be related to home environment. It might be related to social issues. But there is no doubt that we're going to see more and more of our healthcare workers also affected. Now, in the midst of all of these issues and the increasing number, there are two other issues that we are facing that are a problem for all of us. One of them is obviously it's a flu season, and I think the MEC has spoken about that. But the second reality is that unfortunately our emergency department not only are inundated with patients that are coming for acute care, but we are also seeing the trauma load going up more and more with different levels of lockdown. You know, it reminds me of the days when we were doing the World 2010, and at that stage, one of our trauma numbers had gone down. It was again one of the unbelievable times in this country. May I remind you that this country sees more trauma than what you find in a war-torn area. And unfortunately, that trauma is preventable. Most of the trauma we see is related to us. It's related to how we drive on the road. It's related to, unfortunately, also the element of alcohol. 60%, different studies have shown before. I can assure you during some festive periods, we know that at least 80% or so of the injuries that we're seeing are related to trauma. So again, we are asking that for us to be able to work with this load that's already stretching the healthcare workers, for us to be able to shift some of our healthcare workers to be able to assist more in these COVID-loaded areas, it will be very, very helpful if in the meantime what is preventable and what can be managed is also given as much attention as possible. And I'm afraid alcohol does contribute to trauma. I'm afraid most of the trauma that we're seeing is preventable, and we need to be able to deal with that. And our numbers show, if you look at what we had on level 3, we had gone to about 20% of the usual load of trauma that we see. That was when we were still on level 5. Then when we went to the next level, we started to pick up about 60% of what we were seeing before. And I can assure you now, since we have moved to level 3, those numbers have started to go to about 80 to 90% of what we are normally seeing in trauma. We cannot afford to deal with multiple pandemics at the very same time. And I think if there is one plea from my point of view, is that all of us must face the reality that this problem is here, pandemic is for all of us, and the only way we're going to do it is everybody playing his main role. We can't approach this as one institution, it's a cluster approach, and I think the MEC has said that over and over again. We have to be able to make beds available as much as we can. And what we are saying to people is that the plans you had 2 weeks, you need to revise them because of what you've had now. They may not be sufficient today, and that's why we're looking into this active jock type of active readjustment based on the loads that we're seeing. But as we manage the COVID load, remember as healthcare workers, we still have non-COVID emergencies that have to be managed. So if we can reduce those that we can adjust, if we can reduce the trauma and behave, if we can have responsible drinking, then hopefully the load to the healthcare worker can be managed. My last word, again through you, again, Premier, is that it's a reality that a lot of healthcare workers really put themselves out there. And I hope that when we behave and we do what is right, we are actually thinking about the healthcare workers that really need to have an opportunity as well to be able to survive this period with less casualties than what we could have seen if we didn't make a plan. On that note, I thank you very much.
Thank you very much, Prof. So obviously one of the issues that the MEC will deal with during question time is our collaboration with private health institutions, private health providers. In all the numbers we were talking about today, we didn't make provision for that, but he will deal with that as an issue during question time about the SLA and the MOU that we have signed with private providers in our province. Again, to come in between as we are rolling out additional capacity. So in conclusion, so what is it that we say needs to happen? The storm is here. So the first thing I would like to say is that the month of June has seen a sharp spike in the number of confirmed cases, especially daily COVID cases in Gauteng province. As you would know, we started level 3 during the month of June, but already towards the end of May, we were worried about 300 cases a day. We are now at 3,000 cases a day. Just between the last week of May and the end of June, we are at 3,000 cases a day, when we were worried about 300 cases a day. Gauteng now has the largest number of active cases, and this is something we must build in our heads, in our minds. and not be preoccupied about who's got the largest number of cases. We must say in our province we have the largest number of active cases as a result of the daily infection rate, what is happening. So you would see we have a dramatic drop also with regard to the recoveries, because recoveries come after 14 days. So the more daily cases we have, the less the recovery rate we would have as a province. We have an exponential increase over the last 14 days with regard to hospitalization. Hospitalization is very, very important. Professor Moeng was just explaining now, and the MEC was also saying it's some of the people who are occupying those hospital beds as part of managing this well. Some of them would necessarily be managed differently. The MEC continuously meet with the teams in our hospitals to improve how we manage people who are under investigation or patients under investigation. But it is important to send this message strongly out there to the people of our province that the hospitalization rate has dramatically increased, but also the mortality rate has increased. Although the mortality rate is still low, but the more people you have in hospitals, especially we also, even with that, we have more people on ventilators now, 144 people. We used to have just a month ago, we were having only 4 people who would be on ventilators. Now we have up to 144 people on a daily basis on ventilators. This is something very, very important to send out a message there that the storm is here and we have to weather this storm together. The health services and our health workers are under pressure. That message from Professor Moeng, who comes directly from the battlefield, it's very, very clear. And some of the pressure is a result of trauma units that are occupied as a result of something we can particularly control. Our health services are feeling that pressure already. It is important to also observe that the pandemic is running slightly ahead of the projected models. The numbers are not very far from the projections, but it is our sense that what may have been projected with regard to the end of July, we may have more, because models are a function also of a very dynamic process of bringing in data. And the modeling team the data was different between May and now as a result of daily infection rate. Now we have higher daily infection rate, and the model is going to show that the pace at which the pandemic is moving is much faster. This may have a lot of implications that our advisory committee will look at, including whether indeed the peak will be in September or it may be actually earlier in August. We saw that in the Western Cape actually their numbers are beginning to come down. It is something that the pandemic got there before they had it. We can't rule that out even in our province. All we know is that the month of July is going to be a very difficult month. The people of our province must understand this message. Running up and down, just going to marches, because there have been a lot of marches organized over, some for good causes, especially the marches around gender-based violence and the killing of women have really been inspired by the outrage that is out there. But even with that, even with marches like that, we want to caution the people of our province. It is in those places where the people are going to contract COVID-19, but also with funerals. We have seen in some of the funerals, even there, when people are outraged by what may have happened, there must still be compliance. People go to funerals and they don't quite comply with the existing regulations. One of the important things I would like to quickly show you is what one funeral has done in an area in the northern part of our province. Just one funeral in Mabopane, in an area where a month ago we had very low numbers in Mabopane. The team, our law enforcement team, actually had to go to that funeral to be able to say this cannot be the case. And after that funeral, you would see what is the situation in that. Now, on this slide, you would see the size of the dot is an indication of how many infections have happened. So if you see there is a big red dot there that says Mabopane, Karankua Mabopane area, where we had just one funeral, which was the source of big infections. Because often our people take this for granted, as Professor Moeng was saying. These messages that we've got to, even when we have funerals, people need to do this in accordance with lower numbers. We ensure our people wear masks. There's sanitization. Unfortunately, people are passing on at a very difficult time. We understand, especially family members need to be at the funerals, but we want to say in our province that these are some of the issues that we really want to go back and deal with this. I say there's marches getting organized. The police have been saying to us, they wake up one morning, there's a march there, there's a march in that area, and it is those kind of activities of crowding in public places that are causing a problem for us. Some of these infections are also a result of cluster outbreaks. The mining sector in our province has been critical in the West Rand. And you would see that some of the areas, it's not just Merafong now in the West Rand. You also have Randfontein, you have Mohali City and Rand West. And they have they have a huge impact on the western side of Soweto. Dobsonville, Doornkop. And that's where we have the largest number of infections in Soweto. Those infections are coming from the Doornkop, Dobsonville area, and it is linked to the mining activity of the western part of our province. So the cluster outbreaks have a huge impact in that regard. We also having headache with regard to the opening of business activity in the CBDs of our province. Lots of people moving in and out of our CBDs. The economy is open in those areas. And again, people just behaving when they do shopping in those areas, behaving like COVID is something that's not here. It's a big concern. If you look at where the big numbers are, in Johannesburg, the CBD of Johannesburg will be a big concern for us. In Tshwane, the CBD and the western part of Tshwane will be a big concern for us. Again, there is a link between more business activity in areas to the recent infections that we have had in our province. So what are the implications of all this? In our concluding remarks, we say that one of the things we are really looking at is focusing on behavioral change. Behavioral change, we now have more than 200 ward-based response teams. And the data that comes from our modeling team, that comes from our data team, that says, in your area, this is where the problem is. We are now directing it directly there. So we have more than 200 active ward-based teams. They are focusing at ward level. They are still trying to find their feet. They are working with health workers, but we want to direct them basically to households and get our message out there. There's no way we will win the war against COVID-19 by just using the police. We need to appeal to our people. We need to mobilize people. Our messages need to get to people so that they understand. They are the ones who can make the real difference. So behavioral change is very important, because we are also seeing that over time there is a sense of fatigue in some of the areas. So where we even had very good observance of regulations, observance of social distancing and wearing of masks. In 1 week, you just go back to that area, you find that people are no longer wearing masks. So we do have a significant problem with regard to observing this hygiene as well as the non-pharmaceutical measures. So we will rely quite heavily on our citizens and communities. And that's why we are activating this ward-based response team. Will that be enough? We think no. Yes, we need this. We need citizens to do this, but we also thinking that we may need, as the Provincial Command Council in our province, we are having consultation processes to look at making representation to the National Command Council on reinstating some of the harsher stringent measures. And what do we mean by that? So basically, in addition to ward-based response teams, we think there are areas, there may be a case for localized lockdown, harder lockdown being localized in some of the areas where things are just getting out of hand. The infection rate is just getting out of hand, and people are not observing any of the measures that have been put in place. We will have our meeting this Saturday. So this Saturday we are doing consultations. As the Premier, I'm speaking to all the political parties in the Gauteng legislature tomorrow, but we are also talking to the various sectors in our province about exploring some of the reintroduction of the harsher measures. Some of them may include issues pertaining to alcohol. We can't say what exactly, but you heard Professor Muyeng saying what alcohol is doing to the trauma units and the beds, the bed capacity that we have had. Now, we can't make the decision. It is only the National Command Council, but a risk-adjusted strategy means you look at what is happening in the particular hotspots. And if a particular area, the situation is getting out of hand, a risk-adjusted strategy means you can make a case that a different approach may be needed. And for us as a province, given what we are going through now, and that things may get even worse in July, given that our winter is now, the real winter is arriving, the numbers are spiking, we cannot just throw our hands in the air and say that there's nothing we can do. We need the people of our province, communities and citizens themselves to come to party, but we also need the state to come to party. The other thing we are looking at, we know we have been preparing for the next grades in schools to come in. Our Provincial Command Council had a discussion that says we can't bring another million learners into our schools. At the moment, let me show you what our situation is with regard to infection rate. We have more than 700 infections, both learners and teachers in our schools. At the moment, I'm going to take you to that slide now to show you. We are concerned about adding a big number of learners because our system is okay with the grade 7 at the moment and grade 12. We are managing that risk at that level, and we are worried that in the way we want to bring more learners, it may just put more pressure on what the system is able to carry at the moment. And I want to just show you that slide that shows how many. So you will see the number of schools that have been affected by COVID is 589 schools in Gauteng. The number of learners is 184. and the number of educators is 428. So in total, the learners plus the teachers, we have 687 people who have tested COVID positive. We have closed down 71 schools, but as you know, the school is not closed forever. It is closed down when there is a case, decontaminated, and then reopened again. So we will finalize this discussion as we do our consultations on Saturday. Our provincial, we have actually now called the Executive Council meeting, not just the Command Council, the Provincial Executive Council meeting, that's the cabinet, the Provincial Cabinet is meeting. On Saturday, these consultations will culminate in that meeting. We have also asked our advisory council to also meet ahead of that meeting to look at additional proposals and recommendations about what we can do. We can't throw our hands in the air and say there's nothing we can do. Certainly the schools are in our hands. How many schools can be open? How many grades can be open? At what moment? How much can the system take? It's something we can control. And that's something we are looking at. We are also looking at those things we can control. As we say, it is in our control whether people have access to alcohol or not. It is in our control. We know the final decisions especially on this issue of alcohol, gets made by the National Coronavirus Command Council, but we also regulate alcohol as a province. So we are looking at what we can do in addition to what national decisions are. We regulate the hours of sale of alcohol as a provincial government. We can make certain decisions around this, but they must be based on a proper modeling around what the impact will be, what the load will be on our trauma units, are we able to go back to at least 20%, given what? All these things are based on proper modeling, they are based on proper science. So I want to emphasize that there are also sectors even with the reopening of the sectors of the economy, we think at a provincial level, we shouldn't move at a pace that may overwhelm the system. And that's what risk-adjusted means. The national risk-adjusted strategy is essentially about assessing the risk and making sure that that risk is something we can handle. If it reaches a point where we can't handle it, it is something that will create great difficulties for us. So we are looking, as part of the consultations, we are also consulting with the churches, again, to look at that area of where the reopening has happened. Our own data tells us something about them, what is happening with compliance. So we are doing a consultation. All over the world, you know, there are countries and jurisdictions in those countries where if the infection rate just gets out of control, some measures the need to reintroduce some measures become unavoidable. So we as a province cannot throw our hands in the air and say there's nothing we can do. I think the issue of the hospital beds and the staffing are the issues that Dr. Masuku has dealt with in great detail. I want to emphasize that to the people of our province, this pandemic is something that can be overcome. We can overcome it. There are many people who got COVID positive who have recovered. Many of them are public servants. But we have also lost some of our most dedicated public servants in our province. Doctors, nurses, also the police, law enforcement officers. We lost, on Monday, we lost the Deputy Provincial Commissioner General Parasi to COVID-19 as a province. But there are also a lot of people who have recovered. And I want to say my message to all the civil servants who are in the front line of this battle is that to say to them, starting with our health workers, is that we understand the pain that they are going through, including the work, the load that they are now carrying. But our actions as society and as citizens can lighten this burden by firstly appreciating their work, secondly, doing the things that they say we should do. Social distancing, ensuring that we wear masks, ensuring that we are not all over the place. People go all over the place. They are in public spaces when they are not supposed to be there, as if COVID-19 is not there. So as a province, we are determined to face these battles, to face this storm, to contain its damage, because storms do cause damage. We want to emerge from this storm as a province together, across the board, all sectors, the different political parties. So let's work together to face the next month and the next month as we go through this. As the Gauteng provincial government, we are doing the best we can to provide PPE for all our healthcare workers and our essential services workers in every sector. We also speeding up, given the pace of the pandemic now. We're doing everything to speed up the provision of additional beds. We're going back to the people who are doing this work to say to them, if you can deliver this alternative building technology beds 2 weeks earlier, it will help ease the burden on our healthcare services. Precisely because the model earlier on had indicated that we will need more of this later, towards the end of July, we're doing everything now to speed up this process, and that includes the provision of additional field hospital beds. Thank you so much for the opportunity to brief you again. Thabo, you can come back. It is your chance now to deal with questions. The situation is not normal. We can't proceed as if the situation is normal.
Okay, thank you, Premier. We'll start here, and then I'll also read out a few questions here on WhatsApp.
Good afternoon. Crisalda Lewis from SABC Television News. Good afternoon, everyone. Premier, I just wanted to ask about Saturday's Executive Council meeting. I know that nothing will come out prior to the discussions or consultations that you will have, but when are you likely to approach the National Coronavirus Council on some of these decisions that might come out of this meeting on Saturday pertaining to strict restrictions that we'd seen in earlier phases in Gauteng? And perhaps the MEC for Health on this one. Do we know how many hospitals at this stage, MEC Masuku, are nearing not being able to accept any more COVID patients, or perhaps their COVID wards and ICU are full at this stage? There was something that was circulating a bit earlier on. We're just trying to establish the veracity of that. Thank you very much.
Okay. All right, is there another one here? Okay, let me read out a few on WhatsApp. There's a question from Brian Sokutu from The Citizen. Is Gauteng likely to revert to level 4 or 5? If so, what are the processes to be followed? I think, the Premier did speak about this, but he will be able to answer. And the next question is from Arisa Jansef van Rensbeck from Network 24. Please see, it's quite a few questions. How many Gauteng hospitals are full and can no longer accommodate any patients, including those who have COVID-19? Which hospitals are they? Which hospitals are they, and where will patients be transferred to? Oh, I think he meant from which hospitals are they, and where will they be transferred to? What is the situation in Midvaal? There are rumors that both the private and public hospitals there are full. Is that true? Where will the patients be transferred to? Third question, will Gauteng be put under lockdown? Is similar to the one asked earlier. What are the projections looking like in terms of cases of deaths for the coming months in Gauteng? Then Arisa again, it is alleged that there's a shortage of beds, oxygen, and personnel at Krisani Baragwanath. It is also alleged that when personnel wear protective clothing, they cannot eat, drink, or go to the bathroom for their entire shift. Is this true? Then we have a question from, I don't see the name here, okay. Kenny Mapanga from News 24. Are hospitals under pressure and turning people away? What are you doing to recruit more healthcare workers ahead of the storm? Well, as you heard, the Premier said the storm is here. What are the circumstances surrounding the death of a patient at Tembisa Hospital? The patient allegedly tested for COVID-19, but allegedly did not receive the results. He also took his social media page. He took to his social media page to share that he had not eaten in 48 hours prior to his passing. I think the similar question was asked by Malungelo Boy. And Malungelo there says, the family says they were told that he passed on due to COVID-19. And does the MEC believe that the fact that he had not been given food for 48 hours may have contributed to his condition worsening? And then, still from Malungelo, I think related to that, what has contact traces, what are the contact traces for this, or where contact tracing done, or why has contact tracing for this case not done? Then there's another question here from ETV and ENCA, from Graham Robinheimer. How many beds are available for COVID-19 cases in Gauteng now? We did refer to that earlier. The MEC spoke about it. And how many do you want to bring online by the end of July? Then the last question, how many healthcare workers in Gauteng have contracted the virus, and how many of them died? Okay, those are the questions. Let me see, most of them are yours.
Thank you for the questions. Difficult questions, I must say, but some of them are pretty much straightforward because we just have to deal with the facts as they are without putting any other supplementary information to that regard. I will start with the issue that relates to the bed, which we reflected on initially, that in the current state we have an agreement that we have signed with the private hospital groups in Gauteng, which had made available almost 8,330 beds that were there, that were dedicated for COVID. And we have added almost 600 beds in that regard with our work that we have done in repurposing and refurbishing some of the wards that have been there. And I indicated the amount of about 650 to around 700. And these beds are continuously being opened. Like this morning, we opened another beds of ICU. We're continuously opening them as going through actually July. And it's an important aspect that we have to mention that we have formed a bed management team with the private sector, with the private health groups in Gauteng, which dynamically they look at the bed occupancy in all our facilities and be able to shift around patients and be able to direct EMS where they're supposed to be directed for the admission. So in a light that we are trying hard that we don't get to a point where we turn patients away, that is why we have this bed management team, which has got a live dashboard, which receives information and data from both private and public hospitals on that note. So we have not yet got to a point where we are turning patients away. We try by all means to accommodate those patients. That's why we are raising the issue of PUIs and also making sure that we have enough extra capacity in our accident and emergency departments with tents and maquis that will have all the facilities like oxygen and IV management that we can be able to accommodate some of the patients whilst they wait for beds to be triaged appropriately according to their COVID status. And it's an important thing that this process remains very dynamic. Yesterday, I did see that particular WhatsApp that was circulating about hospitals being full and so on. And there was no truth to it because they were at that point when we saw the WhatsApp, the hospitals had almost 120 or so ICU beds across both actually the systems. So it's an important thing that we also have to discourage individuals and people from putting up information that is not truthful into the public platform because it causes unnecessary panic and it causes unnecessary fear. And of course, maybe whilst dealing with that point, we are not saying at any rate that we are not feeling the pressure. We are feeling the pressure. The system itself is feeling the pressure, but it's just upon us as the community and also as health department and our healthcare workers to be able to manage it. We still require a whole lot of effort from the public to make sure that these particular beds that we're talking about are pretty much available for those who will actually require them. So throughout the month of July, we will be putting up these field hospitals which will make up for the gap that I've spoken about and will make up and be ready for when we get to when we have maximum infections for a longer period in the province. And that work has started in Sinaba, the work has started in Nasrec, and in due time we'll be able to call you as the media to come and view some of these beds as they become available and they are ready. And this is a work that will continuously be done in July. I think it's important also to mention that putting up also fake news is a big problem. I don't think it is humanly possible, or any supervisor for that matter, who would advise that people might not be able to answer a call of nature when they're wearing PPE. I was in Bara myself yesterday and with the national leadership of NEHAU We met with the labor unions. We appreciated the challenges that they've raised, and we also raised some of the problems and appreciated some of the work that has been done by the hospital. So some of the things, yes, they might be out there, but they might not be pretty much true in that regard. As it relates to the human resource, over a period of June, we have almost employed over 4,000 healthcare workers in different hospitals, and we are continuing to do the same. We're also putting up what we are going to call an extra force or a reserve force of healthcare workers, which will be able to be deployed at different types or different places or facilities where we require help. And this is the work that is continuously and it's being done by our human resource team. And it's also going to tap into what the South African National Defence Force will be offering, and it's also going to tap into the private sector, particularly the companies that are known to be nursing agencies, to make sure that we're able to get enough staff, because the more our staff members get infected, the more that we need to replace and replenish. And besides being infected, we also need to have enough reserve force to be able to replenish and refresh our staff in terms of fatigue and actually resilience. I would want to address the last issue. I think the issue of the Tembisa patient. We did receive the call from the public, particularly from the leadership of a youth organization in Tshwane about the said patient on Friday. We referred the matter to the institution and the facility. And when we had to receive the report back, we were then informed that the patient had actually passed on. The team from the MEC's office have been dispatched there this afternoon to go and meet with the family to ascertain the process that we're going to follow as the Department of Health in terms of getting the reports from the quality assurance team, who will investigate, do interviews with the staff that were involved, and get a proper report, so that we don't work on hearsay. We work on the fact that will be put across by the report. Family will be interviewed, everyone will be interviewed who was involved, so that we can then respond as a department on the basis of full report on what has actually occurred. It is a regrettable situation, as it came across in the social media, that a patient would be stabbed whilst they're in actual hospital. So it's something that we're investigating, and we don't want to say anything after we have ascertained the facts as they are. But maybe just to conclude is that the bed management team is hard at work to make sure that we don't turn any patient away. That is our objective and our will, to make sure that the healthcare system is able to take care of all the patients and be able to be treated in that space. So the work that we are doing currently, that we have put into place, will be able to cover that. Field hospitals, the POI tents in different facilities will come in handy, and fast-tracking our construction of the extra beds that are there. We will be doing that in the coming months and in the coming weeks, and actually days, weeks, and months, so that when we get to August, which is not far away from now, we should be having enough capacity to be able to deal with. And we are working very closely with the private sector in this regard, and the team itself has got a dashboard that we look at it. And of course, some of the things, they should be substantiated, because sometimes we won't be able to deal with rumors. And I think it's important when we answer the questions, we will be able to answer them particularly based on the facts, not only on rumors. Thank you.
I would like to deal with the question about after Saturday EXCO meeting, when will we consult with the National Command Council? I want to emphasize that we are having consultations at the moment. One of the things we will also do is to have their ministers and deputy ministers who have been deployed throughout the country to hotspots, COVID hotspots throughout the country. They've been deployed by the president. So they will also be joining our meeting. In fact, yesterday we had a briefing session with them. They will be joining our meeting on Saturday because they have been deployed by national government to hotspots to also be able to bring some national wisdom, but be very close to the issues and come face to face with the issues and hear what comes from the ground on those issues. I can't say yes, definitely, Griselda, I can't say what the actual decision on Saturday will be, but as soon as the Provincial Executive Council has arrived at a decision, as I say, we will do so after consultation with the various stakeholders in Gauteng. That process of consultation has actually started. We will do so and be able to inform the National Command Council. It is clear that the National Command Council makes decisions on the issues of localized lockdown. And I can't say, there's a question about whether Gauteng will revert to level 4 or level 5. I think it is early. We want to ensure that when we make this intervention, it also takes into account all the various needs of our people, and all the various needs of our people would include making sure that we don't go in the direction that would not be unsustainable. But exactly what that would be, we're going to get advice from our advisory committee. We're going to get inputs from the different sectors that we will consult with between now and end of day tomorrow. My work is really going to be to consult with those various sectors so that whatever final decision, which will be a recommendation, our Provincial Executive Council will come to a decision, but it will be a recommendation to the National Command Council once that is arrived at. But there are also things that are within our power, because the reason I am calling the Executive Council tomorrow and not the Command Council is because as the provincial government, we've got certain things that are within our power. I gave an example earlier on that the issue of regulation of alcohol is something that is firmly within our power. We cannot ban alcohol, we can't suspend the sale of alcohol, but the regulation of alcohol is firmly in our power. Tightening some of those things are things that a provincial government can do. All I would like to say is that the situation is serious, and it warrants a risk-adjusted approach. That when the level of risk increases, as it is increasing, in our case, at a pace that is extremely exponential, that we have a comprehensive response to this. Someone asked a question about projections with regard to the number of deaths in the coming months. All we can say to you is that the mortality rate, even as we face all these challenges, the mortality rate relatively in comparison, the mortality rate in Gauteng is still fairly low. And all we want to say is that thanks to our healthcare workers, our clinicians who are doing a great job to save lives, because if you look at the number of the confirmed cases we have, and check where the mortality rate was in other provinces that have a mortality rate higher than us, you would see that the mortality rate is low. But I don't want to communicate a message that everything is fine. I don't want to communicate that message, that people must not think that, well, in Gauteng is okay, so not too many people are passing on. One of the things around the modeling is that as we get into July and the intersection of the pandemic with winter, the mortality rate will increase much more during this month of July. It will increase much more, but we can't tell exactly how many people are going to pass on. And our clinicians are doing a great job in embarking on all kinds of measures to really, really save lives. And I think so far we want to commend them, but social behavior will help extremely in ensuring that the system is not under pressure in terms of what we do ourselves. Dr. Masuku has addressed the personnel issue. We as the provincial government have made more than R500 million available to the Department of Health from our own budget to address the emergency regarding personnel. It's one thing to build more, to put in more beds, but you need people to be able to manage. Healthcare is about people. It's about the personnel, the healthcare workers. And it is for that reason when Dr. Masuku says the recruitment process has brought in an additional 4,000 workers, healthcare workers to help focus on COVID-19, it is something we have done deliberately. But is that enough? As the pressure builds up, listening to Professor Muyeng, as the pressure builds up, there will still be more need for healthcare workers. The feedback we're getting is that in a whole host of hospitals and our healthcare centers in the province, the demand for more healthcare workers is increasing. So we are attending to it, this issue, and we appreciate the fact that we have been able to add additional healthcare workers in this period. I want to emphasize lastly that the collaboration and cooperation between the private and the public healthcare sector will be crucial. Gauteng has the largest private healthcare sector. Yes, our public health system is the largest because it services sub-Saharan Africa, but the private healthcare sector in Gauteng also has huge resources. So we want to continue to appeal that we as the public healthcare system will not be able to cope on our own. So the meetings and the agreements that the MEC for Health has with the private health providers is crucial to help us go through. Those beds, I must tell you also that also the private health care facilities are themselves getting under pressure. They are themselves getting under pressure. So that monitoring and management of bed availability at a central level is important. We are doing that now. If our beds would be full, we would know which private health hospital has got additional beds where we will be able to bring in people. But even with that, is to help us as we go through the different phases and as we prepare for what is likely to be the peak in August rather than September. So we are doing everything to really make sure that by the end of this month, which is July, we have all the things lined up in accordance with our modeling. Our modeling says first, early August. That's where the real pinch, the peak, will be felt. So we are doing everything, having done some work to recruit more health workers, to add additional beds, and we are continuing to add additional beds. We want to make sure that by the end of July, we are ready for what is the peak. But We are also understanding that July itself immediately the pressure is there. So we want to deal with all these issues. I will await the report from Dr. Masuku about the patient who has passed on in Tembisa. I will await a report to understand the circumstances around this, so that as the government we take if it is clear that there was something that government officials should have done to save life, because every single life lost is one life too many. If we can do something to save life through non-pharmaceutical interventions, and secondly through interventions about providing care to our patients when they present in our healthcare facilities, every single one of those patients matter. So in this particular case, I will wait for the report and then we will take appropriate corrective action. I would like to convey my condolences to the family of the bereaved, all the families of the bereaved so far. And in 1 week now, we are losing many more people. We are with you, and we will continue to be together as we weather the storm. We will weather this storm. This too shall pass, but it will be at great effort. It will be at the level of what we do as citizens and what we do as government and what we do, those who are healthcare workers, what they are able to do. They're already doing a lot, and we want to continue to thank our healthcare workers for carrying the can. Thank you so much. I want to thank the team of our advisory council members. In the document that we are circulating today, you will see, today you only saw a few of them. We have a full team of the advisory council that is in the presentation that we will send through to you to see some of the best brains we have, social scientists, public health specialists, data scientists. We have brought them together to help advise us, and we are going to weather this storm together. It is a tough storm, but we will weather it together, because when we are together, we are stronger than if it is just us as individuals. Again, I want to appeal to the people of our province. Please take COVID-19 seriously. There are people going up and down as we lose more people. Together we can win. Thank you very much for joining us today.